This talk is going to be an introduction to cochlear implant programming. It covers the adult and pediatric cochlear implant introductions, readings that are posted online. While there are many challenges in cochlear implant programming, one of the main difficulties is the dynamic range problem. Being able to take the dynamic range for human hearing and compress it down into the dynamic range for the electrical hearing for the cochlear implant candidate. We know we have a similar but lesser problem that occurs with hearing aid users, where we're trying to take the dynamic range of normal hearing, maybe approximately 120 decibels if we're talking about on the low end detection threshold, and on the high end feeling of discomfort. Maybe a little less than 120 decibels, but roughly that. We're trying to compress it down into the residual dynamic range of, say, the hearing aid user. We realize that detection threshold for the hearing aid user may increase, whereas the upper boundary, being the loudness discomfort level, may increase, but to a lesser extent. The problem is even larger with the cochlear implant candidate because the residual dynamic range that we're working with is very small, typically no greater than 20 decibels, maybe even as low as 10 decibels or less. So we're trying to take this 100 or maybe 120 decibels dynamic range of normal human hearing and compress it down into 20 decibels or less in terms of the electrical dynamic range. So we can see on that right side that we have a figure showing this exact issue, where we've got that very wide dynamic range of human hearing, compressing it down into that more narrow dynamic range for cochlear implant users. That's one of the first problems that needs to be resolved. And this way of doing it is depending on the kind of speech coding strategy that's adopted, and that with other characteristics will define the map, or really what is a program when we talk about hearing aids, but more commonly referred to as a map with cochlear implants. So I mentioned that for a dynamic range, the boundaries of the dynamic range are determined by detection threshold and loudness discomfort level. That's what I was mentioning for, say, hearing aid users, and that's what we're pretty familiar with. So similarly, detection threshold does define the lower bound for dynamic range for electrical hearing. And so behavioral measures are going to be the ideal way of doing this if possible. So this will be for, say children who may be, maybe 6 months and older, or possibly, depending on the age, maybe 6 months and older. You can obtain behavioral measures, as well as adults, of course. And so detection thresholds for adults, you may use just conventional audiometry. For children who are, say, 5 and older, conventional audiometry. But similar to just pediatric testing in general, we'll have condition play audiometry and visual reinforcement audiometry for the age-appropriate populations. Now, one of the things that's going to differ between hearing aid users and cochlear implant users is the upper bound. I was mentioning the upper bound for a hearing aid user would be the loudness discomfort level. In this case, the upper bound is either going to be like the maximum comfortable listening level, but of the three hearing aid of the three cochlear implant manufacturers, they don't all adopt the same kind of criteria. Some of them may use the maximum comfort listening level. Some of them may use most MCL, or most comfortable listening level. And in this figure below, you can see that the arrows pointing upward represent the detection threshold, the electrical level required for the person to just barely detect the sound, and the arrows on the top facing downward, those are going to define the, say, maximum comfortable listening level. And when defining these most comfortable or maximum comfortable listening level, especially with children, loudness scaling using visual imagery may be particularly helpful. But what about those cases where children are, say, less than 6 months, or maybe they're also developmentally delayed? How do we determine detection threshold and that MCL, or maximum comfortable listening level, when we are working with those populations? And we can do that. We can look at first some electrophysiologic measures or electroacoustic measures. We have the compound action potential, but it's electrically evoked. That's similar to the compound action potential we measure with the electrocochleography. The main difference there is going to be, instead of having an acoustic stimulus being administered via the speaker in the ear canal or the transducer in the ear canal, it's going to be administered via the cochlear implant processor down to the electrode. We have the electrical stapedial reflex threshold. So again, just the acoustic reflex threshold, except we're using an electrical stimulus being administered by the implant processor. And then third, the electrical auditory brainstem response. Again, similar to a standard auditory brainstem response, except instead of having the acoustic click stimuli, we're going to have an electrical current being sent down to the electrode to the cochlea. So first, let's define what an electrically evoked compound action potential is. So what we're looking for with this particular physiologic measure is what is the lowest stimulus level, in this case the electrical level rather than the decibel level for the auditory signal. We're talking about the electrical level of the current. What level is required to elicit a auditory nerve response in response to electrical stimulation on our monitor? You know, what's the lowest level at which we can see a definitive response, especially when it replicates? And again, the implant processor is what's going to deliver that electrical stimulus. This is going to be an adjunct to behavioral measures, but it should not be used alone in the absence of behavioral measures. It doesn't correlate well enough with detection threshold or most comfortable loudness level. Either one, it doesn't correlate well enough alone, so it shouldn't be used in isolation. However, all three cochlear implant manufacturers have this particular measure integrated into their software, into their implant processor. It just goes by different names. Neural response imaging for advanced bionics, neural response telemetry by Cochlear, and auditory nerve response testing by MED-EL. So what can the electrically evoked compound action potential be used for? Well, for one, it can be used during cochlear implant surgery intraoperatively. It can be used to confirm device functionality. It can also be used to confirm audibility postoperatively. So say, for example, you've got a pediatric client and maybe their behavioral responses are not the best. You can confirm that signals are audible for them using the electrically evoked compound action potential. And next we have the electrical stapedial reflex threshold. And if we're going to use an operational definition for this, it'd be the lowest electrical stimulus level that elicits a reduction in admittance, because remember, when we're performing a stapedial reflex testing, we're looking for that change in admittance, or when the middle ear muscle contracts, a reduction in admittance that we attribute to the middle ear muscle reflexes. So again, we present the electrical stimulus through that implant processor, which goes down through the electrode array into the cochlea. But we're using a conventional middle ear analyzer, a conventional admittance unit. We're performing contralateral stapedial reflex thresholds. So we've got the probe detecting the change in middle ear admittance on the ear contralateral to the cochlear implant. I'm not sure if this is going to work so well if you have bilateral implantation, because having the ear that it's implanted will make it less likely to be able to detect that reflex. But in cases of, say, unilateral implantation, you'll have the stimulus on the cochlear implant side where the processor is at, and you'll measure the reflex on the contralateral side. So remember, the stapedial reflex is consensual, meaning it occurs on both sides whenever it's activated on either side. This is a particularly useful electroacoustic measure, physiologic measure, because there is a very strong correlation between the electrically evoked stapedial reflex threshold and maximum comfort levels. Interestingly, this topic has been looked at unrelated to cochlear implants in just persons with sensorineural hearing loss for many, many years. And there was many papers that investigated this topic, and there was some type of relationship between MCL or UCL and stupidity reflex thresholds, but it just wasn't strong enough of a relationship to be predictive. Well, it seems that now it's been made more useful. That relationship has been is stronger, at least in cochlear implant recipients. Drawback of this particular measure is if you have a history of, say, middle ear disease, so similar things that would affect stupidity reflex in any particular client. If you've got a some kind of abnormality that's distal to the actual ossicular chain. So if, say, for example, there's a problem with the eardrum, maybe it's scarring, or maybe it's atrophy or something like that, that may have a negative impact on being able to detect the acoustic reflex threshold. Of course, that's going to have an impact here as well. But this stupidity reflex threshold, electrically evoked, in particular in pediatric clients, can be useful in setting those maximum comfort levels. Then we have the electrically evoked auditory brainstem response. It doesn't receive as much attention as either the ECAP or the ESRT. Not as much as the ECAP because it's not, I don't believe it's built into the software. I believe you're using a conventional ABR unit. And then not as much as the ESRT because it doesn't really, doesn't have as much clinical value, I'd say. The latencies are going to be a little bit earlier than a conventional ABR, maybe done intraoperatively or postoperatively. In the past, some cochlear implant facilities have used ABR threshold in the highest response amplitude received with the ABR to substitute for behavioral detection threshold in MCL, but my understanding is it's not terribly popular nowadays. So as I mentioned in the very beginning, the speech coding strategy is what is used, the algorithm that's used in order to take the physical parameters of what we hear as sound, the timing, the frequency and intensity characteristics of sound, in order to convert them into the electrical signal. We already talked about the dynamic range problem, where we're having to take a much wider dynamic range and compress it into a very small electrical dynamic range. And the exact way we do this for all three of these physical characteristics, intensity, frequency, and timing cues, the way we do this is the coding strategy. There are many different coding strategies available across manufacturers, and there may be certain uses for some coding strategies that maybe make them superior to others depending on the number of electrodes available, probably as well as other factors. But in addition to the speech coding strategy, you'll have additional characteristics that may be adjustable in the manufacturer's software, but again, there is some variability across manufacturers. These are pulse width, which is synonymous with stimulus duration, frequency allocation, and then stimulus rate. Here is a listing of the variety of different speech coding strategies available in the three cochlear implant manufacturers that in the United States. So you can see that there are many more cochlear implant recoding strategies than there are, say, hearing aid prescription algorithms. There are some. The only one we see here that's available across all manufacturers is CIS, which is one of the older algorithms, standing for, I believe it's continuous interleaving stimulation. And then the high res, we can see those are all for advanced bionics. Speak is also a generic one that's been around for a while. Some of these are going to be manufacturer specific, and some of them are going to be more generic, like CIS. One of the parameters that may be adjusted after choosing that speech coding strategy and after activation with the cochlear implant recipient is pulse width. And so here's a figure on the bottom here showing the typical biphasic pulse, that's electrical biphasic pulse that's used with cochlear implant stimulation. So on the y-axis, that's going to be our current, or really our electrical level, and on the x-axis is going to be time. And we can see that pulse width as defined by the difference between, say, the peaks of the pulse there, that's stimulus duration. As it gets wider, may have an impact on the intensity of the signal. So as we increase the pulse width, the intensity increases. So this is really affecting that intensity domain. Remember I said that intensity, frequency, and timing are the three physical characteristics that we need to think about how to translate them or transfer them over into electrical stimulation. And so intensity in general is going to be the product of the current amplitude. You can see that's in milliamps here on the y-axis, with pulse width. And the product of those two is going to be in a unit of nanocoulombs. That's going to be represent your intensity. And this pulse width measure, you can have it fixed across all electrodes, or you can have it change depending on the electrode channel that you're referring to. A second parameter that we can adjust is frequency allocation. This is one of those parameters that's going to have an impact on the frequency domain. So by default with any of these cochlear implants, the frequency range is going to be automatically assigned depending on how many electrodes are active and the speech coding strategy. Ideally you might want all of your electrodes to be active, but that doesn't always happen for a variety of reasons. So incomplete insertion into the cochlea, maybe you've got ossification of the cochlea, post-meningitis, and some of those deeper inserted electrodes aren't really going to be aren't going to have a low enough impedance in order for them to work. Some of the cochlear implant manufacturers will let you adjust these frequency allocation tables. Some won't. So, for example, within a given channel, there are frequency boundaries. So just like maybe 300 to 600 hertz, or just arbitrarily think of some frequency range that with the highest and lowest frequencies representing their boundaries. Maybe you can alter those boundaries to some extent. Or you can choose entirely different frequency allocation tables. When I'm saying frequency allocation, I'm referring to what is the relationship between the physical input frequency, the acoustic frequency of the sound, and how does that relate back to the electrical stimulation to a given electrode. And so we would normally want the electrodes that are placed most basally to be represented by higher frequencies, and those electrodes based most apically to represent the lower frequency electrodes. But the exact relationship between the two is going to vary per an individual, and it's good that we have some flexibility to control that. So when you might change from one entirely different frequency allocation table to another, that may be based on differing psychoacoustically derived approaches. So there may be different theoretical reasons to choose one versus the other. The third parameter to talk about is stimulus rate. This is going to affect encoding in the time domain. This is going to be just the number of electrical pulses per second delivered to the electrode array. So typically this is going to be we can have higher or lower stimulus rates. The earliest multi-channel cochlear implant systems use fairly low stimulation rates, say maybe less than 500 or less than 250 pulses per second. This will still allow the cochlear implant recipient to receive information related to the temporal envelope of the signal, but it doesn't allow information related to the temporal fine structure. In order to do that, we need to increase the rate to greater than 2,000 pulses per second. So the reason we need to increase the rate in order to get the temporal fine structure information is we need that auditory nerve to fire synchronously, and in order to do that, we need the auditory nerve fibers to follow the stimulus on a cycle-by-cycle basis, but that won't be able to happen until we get it up to a high enough pulse per second or firing rate. This is related to the volley theory or volley approach, maybe back for a topic on anatomy and physiology that you may have talked about for just auditory nerve firing in general. We won't go into any detail about that here. Although in theory these higher pulse per second rates will be better for most people, in reality that doesn't always turn out to be true. For some particular patients, the optimal stimulation rate may be much lower, so there's going to be an aspect of trial and error involved there. But in general, we do know that as the rate increases for the stimulus rate, the signal is going to get louder, and that's going to be related to temporal summation. And also, as the rate increases, it will get a higher perceived pitch by the patient, but that's mainly from, say, 50 to 500 hertz. But just like with hearing aid fitting, just measuring pure tone thresholds and loudness discomfort levels, for example, doesn't always get you to where you need to be. With hearing aid patients, we know that we may need to adjust gain or the frequency response to make them more desirable for the patient in the long run. So fine-tuning, I guess. Fine-tuning is going to also occur with cochlear implants. Balancing loudness perception across the electrodes is going to be one important thing to do. So you have different electrodes. Maybe you might have 22 electrodes, and not all of them may be active. Maybe you've got 12 or 15 electrodes active. And each electrode is going to be responsible for a certain frequency range. It may be associated with a certain frequency range. And so one of the things that's been shown to be important with cochlear implants is providing equal loudness perception across electrodes. This may sound familiar in terms of hearing aids because we talked about it in terms of loudness equalization with hearing aids, where you wanted equal loudness across frequency for the hearing aid user, and that was the basis for NAL. So here we want equal loudness across electrodes. Having equal loudness across electrodes will minimize discomfort and improve sound quality, and maybe even improve speech perception. Sweeping is related to that. That's just the process of moving from one electrode to another, presenting a fixed stimulus. It may be at near the maximum level, it may be at 50% of the electrical dynamic range, but it's just sweeping from one electrode to another, kind of like when we sweep MPO for hearing aids, making sure that loudness is equal across, or that at least that there's no discomfort when they're sweeping at a maximum level. Now, for this particular task, not all patients are going to be able to do this. For children, you're probably looking at 8 years and up in order to be able to do this, and it's also going to depend on linguistic development or cognitive development as well. Additional fine-tuning might come in the form of modifying the frequency boundaries. So normally with cochlear implants, we want to provide a very broad frequency range. We want the cochlear implant recipient to have as great of access to sound as possible. But we know that there may be some subjective responses that are negative, and we know that this may be because, say, we have too much high-frequency information. So maybe we can lower the high-frequency boundary of that most basal electrode. This may be due to frequency deprivation there. Maybe it's due to not really many neurons that have survived that are associated with that characteristic frequency. We may have too much low-frequency information, so maybe we need to increase the low-frequency limit of the most apical electrode. So those are just like simple modifications we would also make in hearing aids, but in different ways. Also, frequency shaping. Changing the gain on a given electrode is kind of like changing the gain in a given channel for a hearing aid. Changing the upper limits of dynamic range on one or more electrodes, well, that's similar to changing the MPO on a hearing aid. I'm trying to draw these parallels as much as possible. It's helpful for me, so I hope it's helpful for you as well. They may not always be perfect, but hopefully they're helpful. The input dynamic range is another variable that can be adjusted in many of these cochlear implants. So we talked about trying to take that dynamic range of 100 to 120 decibels and compressing it down into that 20 decibel electrical dynamic range. The truth of the matter is, though, we narrow the dynamic range that we're going to work with at the input first. So we don't try to take 100 decibels and push it down into 20 decibels. We're going to probably have somewhere between 40 and 80 decibels that we're working with on the input to push down to that 20 decibel electrical dynamic range. And this is adjustable. This is an adjustable characteristic. So you can see here the T level on the right side for the cochlear implant is threshold. The M level is that MCL, or the maximum comfort level. And so here we're compressing it down as well. and anything above or below that input dynamic range, if we imagine that we chose that 75 dB dynamic range, anything above 80 dB SPL or below that 20 dB SPL, we're just not even addressing that. It's just not even detected or picked up. It's just completely ignored. For those things that are below 20 decibels, that's probably good. That's probably not going to be a lot of speech information. It's probably going to be a lot of environmental or ambient noise. And there's not really many speech sounds that are above 80 dB SPL, maybe 85 dB SPL for some of the back vowels, maybe some of the louder signals, but not much really above 80 dB SPL. One of the parameters that some of the manufacturers may let you adjust is the microphone sensitivity. And while this does not change your input dynamic range, say for example if we set it at 40 decibels, it's going to be at 40 decibels regardless of our microphone sensitivity setting. But the less sensitive we make the microphone, i.e. the farther we move it to the left on the microphone sensitivity scale on the x-axis, the higher up we shift that 40 dB input range, and the more sensitive the microphone, so farther to the right, the lower down we shift that 40 dB dynamic range. So we can see that if the person wants to hear, more softer sounds for certain maybe high frequency phonemes, we can shift that microphone sensitivity to the right. If they're being very bothered by some of those environmental ambient noises, we can shift that microphone sensitivity to the left in order to shift that dynamic range upward. So assessing internal hardware function is also a necessity that I don't really draw a parallel with hearing aids quite as much. It's not quite the same thing. So with impedance telemetry is the term used to assess the functionality of the system. So with impedance, we know we're measuring the opposition to current flow through the electrode as well as the patient tissues. So one component of that is the resistance. This you're going to typically do before every programming session with a cochlear implant, kind of like before every ABR you might run. You're going to measure impedance first. So the ideal impedances for cochlear implants are going to be greater than 1 kiloohm but less than 20 kiloohms. For those electrodes, and you're going to make these impedance measurements for each electrode, and this is going to be done within the cochlear implant programming software. This should be very straightforward, I believe, in the software. So for those electrodes that have a very, very low impedance, less than 1 kiloohm, one possibility is that they're two adjacent electrodes are in contact with one another, so they short it out, so it's a short circuit. And so in that case, probably one of those electrodes needs to be disabled. The inverse of that, where the electrode impedance is very, very high, greater than 20 kiloohms, would be referred to an open circuit. That might be because of, say, ossification in the cochlea, maybe some kind of a common cavity. So there are other issues where the impedance may be abnormally high. But that impedance, depending on the situation, that impedance may get lower over time. So it may be one of those that you either lower gain on, it may be one of them that you disable and come back to it later on down the road. So that one may not be something that has to be totally ruled out. The cochlear implant manufacturer can also do specialized testing above and beyond what the cochlear implant audiologist is doing. That would be called integrity testing. Just a couple other issues related to the electrode impedance and the electrodes in general. Facial stimulation is a very common side effect of really perception of some kind of non-auditory signals. Could be tactile perception. So facial stimulation or tactile perception in general is a common side effect of electrode stimulation. And sometimes you can see this in the patient with facial twitching or grimacing, or just kind of discomfort on the face if it's a child. In those cases, it may be needed to just lower the gain on that electrode, or maybe to deactivate it if it cannot be adjusted to make it acceptable. And as I mentioned a little bit ago, with even if you have, say, a 22 electrode array, that doesn't mean that all of those electrodes are going to be active and usable. There's going to be a certain number of those electrodes that may, say, for example, be in contact with one another. So you have a short. There's going to be some that you may have that abnormally high impedance with. There's an expectation that you may not have all those electrodes available to you. That's going to wrap it up for this section on cochlear implant programming. Thanks for watching.